लेकिन
4 slides, okay?
Okay.
Started.
Discussion. Next. Next. Hmm. Any more page, ma'am?
No, that much.
Okay.
Last 50 second. Organize your thought process. Your 10 minutes has started.
Okay. Hello, I'm Said Taskeen, and I'm one of the exam candidates. I've gone through the case and I'm ready for the discussion.
Okay. So, as you are aware about this is Mrs. Blanche's condition, the GP has sent CA125 and it has turned out to be 450. So,
Okay.
how you are going to go further and what investigation you are going to ask in her case?
Okay. This is a patient and 57-year-old female which had the symptoms of bloating and a mass palpable done by the GP and ordered the investigation CA125. In this patient, the further investigations which will involve, it will be a transvaginal scan, okay, to look for the pelvic organs and to look any ovarian mass. And also, we can do the chest X-ray for this patient. And since her CA125 is on a higher side, it's and depending upon the ultrasonographic features, she might land up to be a likely case of ovarian CA. We can also work out her baseline investigations in terms of her complete blood count, her blood group, her LFT, her KFT function test, as well as the chest X-ray. Depending on that, thereafter we will calculate her risk of malignancy index and see what is the score, and accordingly manage her after that. Before that, if patient comes to us, I'll also take her full history and information relating to her symptoms, whether she has a weight loss or she has a loss of appetite, and what about whether she's menopausal, and whether she has any family history of or personal history of any other cancers, and what was her weight to height ratio, whether she's smoking or not, and what contraceptives were she on previously, and how is her support at home. And also we'll go for a complete examination of her, including the abdominal examination to look the exact mass, and also the internal examination will be done for the patient.
Okay. So in her case, her history is she is 57-year-old. Recently, she has noted that there is distension and she is having bloating with discomfort in her tummy, in her abdomen. Apart from that, her mother died of breast cancer and father is alive who is having heart problem. No other significant history. She's having two kids who were delivered by C-section and smears are normal.
Yeah. As per her history, that is a positive family history of cancer as well as her symptoms. So it looks more likely to be a ovarian cancer case, and we will evaluate her on that lines further. So for that, we want to know her TVS findings. What were the TVS findings, so that we can calculate her risk of malignancy index and accordingly grade her accordingly tell what will be the probability of chance of being this cancer.
Yeah. So after completing the investigations, she has suspected to have a CA ovary. How you are going to manage, or what will be your next steps in the management of this patient?
Okay, so once we get the working diagnosis that she's an ovarian cancer, then again we may have to counsel the patient. We have to inform the patient in a very sensitive manner, in an empathetic manner. We have to break this news for her that most likely it's high chances of going to be in cancer. Then we will refer, after doing the CT abdomen and the pelvis, we will refer this patient to a gynae oncology center for an MDT review, and thereafter the treatment of the patient will be decided. And also, since she will be going through a lot of emotional disturbance and lot of upsetting nature for her, so we will connect her to the Macmillan Cancer Support Group, and also the counseling will be done for the patient. Advocate support will be offered to her, and the further treatment will be then decided by the MDT team of doctors, which will include our consultant gynecologist, cancer oncologist. It will be a radiologist, also pathologist, radiologist, as well as the support groups and the specialist nurse, the Macmillan nurse. So for afterwards, it will be MDT who will decide about this, and in most probably it will be a surgical approach or surgical method which will be employed for the patient.
Okay. So what will be the management in this case, and how you are going to will you describe me in detail the management?
Yeah. So management, it will depend. It will be a surgical. That's the staging laparotomy for the patient, and it will involve a midline incision, and thereafter, once we reach the abdomen, there will be the thorough exploration of the abdominal cavity and the pelvis. We will look about the nature of the growth on the ovaries, whether it's involving the one ovary or the both ovaries, and what are the whether it has involved the uterus, the abdominal implants are there or not. So immediately after entering the abdomen, we'll take the cytology fluid for analysis, and thereafter proceed with the total abdominal hysterectomy, bilateral salpingo-oophorectomy, infracolic omentectomy will be done, and multiple peritoneal biopsies from the utrovesical pouch, from POD, paracolic gutters will be taken for analysis, as well as there will be the lymph node exploration will be done and sent for the analysis. And furthermore, it's suggested to do gentle palpation of the abdominal organs, okay, so as to see whether there's a metastasis or not. Once this is done, the specimen will be sent for the histopathological examination so as to properly stage the condition. And depending on its report and what is the staging, the further treatment of the patient will be done. So once the patient has been done with the surgery, she will be in a HDU care, and her recovery will be monitored. And also during surgery, the WHO safety checklist will be followed. All the risks and complications will be explained prior to the patient, and including her blood group and any reservation transfusion that will be taken care. VT risk assessment will be done. Antibiotics will be given to the patient after any allergies. And after the surgery, she will be having HDU care, and early mobilization will be enhanced, and support groups will be put in touch, as well as the antibiotic coverage and VT risk assessment will be done for the patient, and the proper documentation will be done in her notes. Depending after her histopathological examination, we'll stage her disease, what stage it belongs to. So, if it is an stage 1A or 1B and only up to grade 2, then surgery may be sufficient. But if it is grade 3 disease, even stage 1, we may need to counsel her about the role of chemotherapy. That will involve the 6 cycles of cisplatin, carboplatin, and paclitaxel for her.
Okay. How you will be following up this patient once the patient has been completed chemo and
Yeah.
surgery?
So this patient will be under a regular follow-up, and she will be having the regular follow-up by the clinical examination. The scans will be done, as well as the markers will be done for the patient. And also, since she has a family history of significant family history, she may be also offered a genetic testing and to her family members in case we found some genetic link in this condition. Uh, so she will be followed firstly for every 6 monthly. Thereafter, after 3 years, then annually she will be followed.
Okay. Anything else you wanted to add to any of this question?
Yes, if the chemotherapy is to be given to the patient, then we'll explain her what are the side effects and what are the risks associated with that. Like there can be tiredness, sore mouth, there can be blood counts will be low, hair loss can be there. And again, we'll be assessing her throughout her chemotherapy with the scans to know the condition, whether it's under control or not. And again, a lot of empathy and support groups and counseling will be required for this patient so that she comes out of this condition.
Okay. Thank you. Last
Thank
5 minutes, 5 seconds. Your own reflection on your presentation.
you. Mm, I don't know whether staging has to be like included in that or not. And
Well,
mostly,
it was very well done task because maximum points you could able to complete. Okay. Anybody wants to give her feedback? Anybody?
She did well, ma'am. I think systematically went, but maybe history. Should we ask breastfeeding and all that, ma'am?
No, 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 nothing. See, she's 57-year-old. So, not
No,
that.
cancer history.
Yeah, she asked personal and family history of cancer.
Okay. Support groups, I think
She mentioned, she didn't mention support groups per se. Macmillan Cancer Network, she mentioned,
she told.
yeah, support group per se, she didn't mention. Anybody? One word she missed out, and it is not there in the book also.
Word. Uh,
Yes, ma'am. RMI scoring.
No, she mentioned RMI scoring.
Yes, ma'am. Yes, ma'am.
She mentioned RMI scoring also.
Yeah,
Uh,
ma'am, in this EVS also is important because if there are no like her score is zero, then RMI will go straight with the zero.
Yeah, so RMI scoring.
أحد المواقع التي تعرضت لهذا الاستهداف.
On RMI scoring, you can say that RMI of 200 and more, after calculation, then suspicion of cancer. So that numbering should be there. NICE says 250, but what the RCOG guideline says, it is 200. Okay. So more than 200, she will be referred for cancer MDT. That is one point. That numbering, when you are going to refer her for cancer MDT, whether it is 200 or 250. So according to NICE, it is 250. According to RCOG, it is 200. Yes or no? Yes.
Yes, ma'am. Different,
Yeah.
yeah, 200 and 250.
So
Something.
that number, yeah, it will be better if you will say. Means see, you have to justify each and every point what you are going to say. Very simple
Mhm.
task, very simple task, but then justify. Okay. So RMI will be calculated depending upon the patient's menopausal status, transvaginal findings of
Mhm.
ultrasonography. If they wanted to know, it's better off because it's simple question. So what are the points in the ultrasonography you will consider at 0, 1, 3?
Yeah, ma'am. It's like if it is bilateral, there is ascites, there are solid areas, and it is metastasis and multilocular. So if it is
Ascites.
one score, it will be one.
Ascites.
If it is two
Once,
or more onwards, it will be three.
yeah.
Yeah.
Yeah. So no, nothing of this sort. It will be 0. If one
Yes.
score, one will be there, one finding will be there, then it is 1. And if it is more than 1, then it will be 3 directly. Okay, multiplied by CA125. So calculation of RMI is also important. So it's better off if you will be explaining because they wanted to assess your gross knowledge. It is not a. It is easier knowledge. It is not the in-depth knowledge. So it's good if you will be telling them RMI at what RMI you are going to send consider cancer MDT and what will be your modality of management. Another point which you had missed. Anybody can make it out?
Yes, ma'am. She will be referred to oncology center within 2 weeks. This is the fastest
Yes.
pathway.
Yeah, targeted pathway. That is called targeted pathway or 2-week pathway. So this has not been mentioned in the book also. So if at all it will come up as a SPT. So what will be your approach? Then we will discuss the answer key and we will end the task. Just few points means how you are going to approach the same task in SPT.
Uh, okay. Shall we start with that, ma'am?
Okay, you can start.
Hi, I'm Dr. Taskin, one of the doctors here. I'm speaking to Mrs. Blanche Stricker, 57 years old.
Yeah, doctor, I'm Mrs. Blanche.
Yeah, how may I address you?
Yeah, Mrs. Blanche is fine.
Okay, Mrs. Blanche, I can gather from your notes that you have been referred from your GP as you had the complaints of abdominal bloating and blood tests were ordered for you, and you're here to discuss about that and the further management. Am I right?
Oh, yeah, doctor.
Any other concerns or expectations today?
No, I just wanted to know what's wrong with me because I'm not able to eat properly. The tummy is swollen. It is always bloated. I'm not don't know. I don't know what is going on with me.
Yeah, Miss Blanche, I'm sorry to see about what you're going through, but definitely I'll address your all concern and discuss your reports with you. Before that, it's okay if I ask you questions so as to know you better.
Yeah.
Okay. Can you tell me more about your symptoms and since how long they have been there?
Recently, since last 6 months, I have noted that my clothes are getting tighter at the belly button side, and
Okay.
I noted a fullness in my tummy and not able to eat properly. I'm always bloated, and that's the reason I had decided to see a GP. A GP noted some mass in my tummy, and he was little worried, so he sent some investigation and some scan also, and I'm here to discuss. I hope there is nothing to worry about it, doctor.
Okay. Okay, Mrs. Blanche, and I can see that when we were last periods, are you menopausal?
I'm on menopause. It's
Okay.
almost 7 years.
Okay, and your update with your smears.
Yeah, it's up to date.
Okay, have you been pregnant before?
Yeah, I'm having two grown-up kids. They are 30 and 32-year old. Both was delivered by C-section.
Okay, and any medical illness like hypertension or blood sugars?
What is this hypertension, doctor?
Sorry, I mean to say increased blood pressure.
No.
Okay, and any allergies you have? Any known allergies?
No.
Mm-hmm. Any surgeries done in the past in tummy?
Uh, no, I just had two C-section.
Okay, and are you aware for weight to height ratio?
Yeah, it's 28.
Mm-hmm. And do you have any personal or family history of any cancers?
No. Yeah, my mother had breast cancer. My father is alive, and my mother died of breast cancer.
Oh, I'm so sorry to hear about that. Were any genetic testing offered to the family at that time?
No,
Okay, and Mrs. Blanche, do you smoke?
no.
And are you well supported at home?
Yeah, very well supported.
Thanks for sharing this information. Mrs. Blanche, can I just quickly examine you in the presence of chaperone? I'll have a check on your heart rate, blood pressure, and the feel of your tummy. Is that fine? And the examination down below.
Okay.
Okay, thank you. Okay, Mrs. Blanche. Now, coming to discuss your reports, and I have got a blood test of yours with me. Okay, it's a test that's a CA-125. Are you aware what this test is meant for, or has anyone discussed this with you before?
No.
Okay, do you want someone to be with you as I give you a lot of information?
No, doctor, it's okay. Go ahead.
Okay, I confirmed your name and NHS number on this. Actually, this is a blood test which measures a protein in the blood, and we see its levels in the blood to see, it has got some relation with us, telling it tells us about the chance of some, ovarian cancers or some other conditions also. So I'm a concern for that in your case, the score is it's 450 international units per ml. So I'll explain to you what does this mean. As such, we are not able, like at this moment, we need to go for some further investigations in you, and it will be one of the components by which we can see how likely there is a chance of condition that's the ovarian CA. Okay.
Okay.
Yeah. So
So
we will.
this could be a cancer, doctor. Are you very sure about it?
No, it's not so much specific for ovarian cancer. However, as per your history and as what the symptoms are, we need to investigate further so as to reach to a diagnosis. Okay.
Okay.
Yeah, so we'll go for a scan from down below. That's the transvaginal scan. And from that, we can calculate a score for you, which will tell us what is the likelihood of this being any sinister thing. Can I tell you forwards what does this scoring means and how can we evaluate further? Is it okay?
Okay.
Yeah, so we calculate a score, and if it happens to be more than 200, then unfortunately that means there is high chance of some sinister change or ovarian CA. And for that, the further treatment will be needed in a specialist center, which we call as a gynae officer by a team of doctors. Okay, am I clear to you?
Okay. Okay.
Okay, so
Yes, doctor.
and some cancer specialist, the radiation doctor, the specialist nurse, the lab doctor. So further treatment will be dependent, will be as per them. So, however, if the score comes out to be less than 200, then this needs to be sorted out at this hospital only. Okay.
Okay.
Okay. Do you have any questions for me till now?
No, doctor. I'm just. And if it turns out to be more, so then what next, doctor?
Yeah, next will be it involves a surgery, okay, and that surgery will be done by the experts. It involves a incision, which is up-down incision given in the tummy, and thereafter we explore the inside of the tummy and the pelvis, and it involves the removal of the womb, the both side of the ovary. I'll show you on the diagram, okay, the womb, the ovaries, and the tubes, and some other lining areas of the inner lining of the tummy. So this is all sent for analysis, and also some lymph glands are taken out so as to see what is the separate of the cancer. So all this is sent to the lab doctor to analyze it and stage it accordingly. And after that, the further treatment will be decided. Some may need some anti-cancer drugs, okay, so as to totally keep the condition under control. Am I clear to you so far?
Yeah, doctor.
Yeah, I can see that. And I given a lot of information. I'll give you this in written information and arrange a scan for you, and have a next appointment with our consultant. And if you're feeling so desperate, if you're feeling distressed, I can also connect you with the counselor of the hospital, which can help you. Is that okay?
Okay, doctor. And how fast this treatment are going to get completed?
Yeah,
Is there?
we'll try to as fast as we'll go for a quick referral pathway. It will be within the 2 weeks. Like if the condition comes out to be some sinister, we'll just guide you a treatment within the 2 weeks, so as to get the better benefit from the treatment. Okay.
Okay, doctor. Thank you.
Okay, thank you so much.
Okay, okay. Almost last 15 second is remaining. Completed. Very well done. Okay. Anybody wants to comment on this? Shall we go ahead with discussion? So the important points to remember in this task is actually the CA 125 always has only been given, no TVS has been given. So you just need to arrange a TVS. If there is a mass in her tummy, so more likely there will be a mass on TVS, and most probably just give her an idea that although as of now we are not in a better position to tell her exactly what is wrong with her, but if ultrasonography will come up and it will come up with some mass, it will confirm the clinical finding of a general practitioner, then the probability of we will calculate a score depending upon her menopausal status, ultrasonographic finding, and the CA 125. And if that score is more than 200, then the chances of having a sinister pathology in her tummy is very high, especially the cancer of the ovary, looking at her symptoms. Per se, if the ultrasonography will not show any concerning feature, then and the ovaries are enlarged or there is some ovarian mass, in that case again this RMI, the malignancy score, will only be a determining factor where she will need surgery in the cancer center or in the hospital. Whatever modality means, it depends upon our ultrasonography. Once it will become if the RMI will be more, then it is actually nowadays they are offering chemo adjuvant, okay, new adjuvant chemotherapy. So initially they will offer some tissue test, followed by that three cycle, depending upon the spread of cancer. If it is advanced, then 3 cycles of chemotherapy followed by staging laparotomy, then again chemotherapy, and then the follow-up. If it will be early cancer, then only okay, staging laparotomy followed by chemotherapy. Staging basically after staging laparotomy, chemotherapy, the number of cycles will be decided by the MDT. Maximum cycles are 6, and if there will be a good response, then and complete remission of the disease, or complete enucleation of the cancer tissues, then the chances of having a survival is approximately 30 to 40% depending upon her stages. If you are knowing this number, then only CAORI per se is not having very good prognosis. The prognosis depends upon multiple factors. If at all the lady asks you, just give her all the options depending upon the advance means type of cancer, grading of cancer, her response to chemotherapy, all those factor will decide her prognosis. One person, one means per se staging only will not decide the prognosis of the disease. There are newer modalities are also available in this cancer treatment. What is this newer modality, if the patient by any chance wanted to ask you, what is this newer modality? HIPEC? Yes or no? Hello? No.
Immunotherapy, ma'am. Immunotherapy.
Immunotherapy, then HIPEC. The newer tasks are coming about HIPEC there.
Yeah.
Yeah, HIPEC
Mhm.
also. So HIPEC is not it is an adjuvant therapy. It is not a replacement of surgery or replacement of chemotherapy. So it's an adjuvant therapy to this modality, to this cancer treatment. So this, there are newer modality, multiple factors will decide the prognosis. If at all you think that it is very rude to tell her exact time that okay, she is having this much time, and we cannot predict how long somebody is going to survive, so you just give her an answer which is more suitable. Newer modalities are coming up, her response to the treatment, grade stage, her response to the chemotherapy, all these will deciding her prognosis. And we are really sorry for her situation. If she's feeling if she's feeling depressed, or she's feeling emotionally drained up, so she can be in touch with the people who are survival of ovarian cancer, and a support group people along with Macmillan Cancer Network is a support group along with counselor. Okay, so these are all the points which you need to cover up in this task. Or most of the points you had covered up, Dr. Taslim, very nicely. Okay, so my coming to my first question, all the points you had included in the answer key. Nothing new, means I don't have anything extra. Basically, S bar you used. So my answer here is S bar suspected C ovary in case of 57-year Mrs. Blanche with background of bloating, distension. It is not detention. It is distension and indigestion. Referred by GP with abdominal masses. Needs further evaluation and management. In her case, since the CA125 is very high, we need few details of the patients, which is onset progression of the symptoms, loss of weight, loss of appetite, family history of cancer, smear, smoking. These are very important. When means, and whenever you're saying history, now you just justify why you wanted to know. So family history of cancer, smear, and smoking are important risk factor when it comes to cancer. Obstetric history, menopausal history, hormone replacement history, whether she's on any hormone replacement therapy, and social history, including her support and occupation. These are the very important points. Once this has been done, once this has been asked, then we will need a transvaginal sonography for the calculation of RMI. Calculation of RMI, as I told you, will be CA125, premenopausal, postmenopausal, and transvaginal scan. So depending upon this modality, if you are most of the time you will be having time, so you can explain what are this TVS finding, where you will take 1 and 3 as an indicator, and when it will be 0. So simple cyst it will be 0, but if it is bilateral, solid cystic, multilocular or multiseptate, metastasis and ascites, so these are the points where you will be taking 1 or 3. And the score, if it is more than 200 according to the RCOG guideline, then you are going to refer this case under 2-week pathway to onco-MDT. Along with that, now we will arrange an alternative investigations, which will be, one is confirming the stage and spread of the disease by doing a CT abdopelvis with baseline blood investigation if patient needs further chemotherapy or surgery. So regarding the fitness of the patient, which will be baseline blood investigation, including full blood count, urea electrolyte, liver function test, kidney function test, and chest x-ray or CT chest to look for the secondaries. CT chest also can be done. Now, having completed the investigation, what will be the next step in the management of this patient? Why is this important? Very nicely, you said that you are going to once we had completed the come to the diagnosis or in conclusion, then we will come up to this patient and inform this patient in a very empathetic way, and break the bad news to the patient and explain her the further management. The further management will be including cancer, MDT, and plan her care depending upon her case. So if it is an advanced case, advanced cancer, then new adjuvant chemotherapy followed by staging laparotomy is the newer modality. If it is early cancer, then it is staging laparotomy followed by chemotherapy. Targeted pathway. What are the people who are who are the people who are involved in this cancer MDT? It will be your gynec oncologist, pathologist, radiologist, radiotherapist, onco medicine, cancer nurse, and GP, cancer support, and your consultant also. Cancer team will be involved. So cancer support team will be basically Macmillan Cancer UK network. Counselor. Plan of action as per MDT, mostly adjuvant chemotherapy followed by surgery if it is advanced cancer, or staging laparotomy followed by chemotherapy. That will be the plan of action in her case. What will be the approach to managing this case? You had very elaborately told this question. No, I have just mentioned the points, but very elaborately you had mentioned. So the once the patient has been planned, whatever MDT has planned for this patient, we will go as per MDT plan in targeted pathway. So the mostly if it is advanced, then neoadjuvant chemotherapy followed by staging laparotomy, otherwise staging laparotomy. So what is the staging laparotomy? You have to explain. Midline vertical incision, explore. What are the organs? What is staging laparotomy? Basically TH BSO with infracolic omentectomy, and with any implants, any abnormalities are visible on a naked eye, then resection of that those points. Okay, so those, so that the we will have a means the all macroscopic deposits will be removed completely. Followed by that, very nicely, you had mentioned few more points: WHO safety checklist, consent, pros and cons of the procedure, then recovery, documenting her care, sending HPR, and tracing HPR is very important. And further treatment depending upon the MDT, depending upon the MDT. Once she has completely completed her completed her chemotherapy and is in under remission, then in that case she will be followed up symptomatically. Symptomatically, basically, again the same symptoms: bloating, distension, weight loss, loss of appetite, CA-125, ultrasonography. Initially, it might be 3 to 6 monthly. Once she will be on a follow for a longer time, then it might be a yearly follow-up. Uh, Now, next point is genetic testing. So here two members in her family had CA breast and CA ovary. So we can offer her genetic counseling also to just see whether there is any chances of genetic cancer disease. Mm, Further follow up the same way, follow up after completion of treatment, trace HPR, offer this patient counselor support group will be a part of treatment modality. Share the patient information leaflet and a support group link with this patient. Okay, very nicely done. So communication with patient and families, explain the rationale for investigation being ordered, discuss differential diagnosis, but here actually less likely differential. Only you can say that benign condition or means or a malignancy. That time when you are not when you are having CA-125 TVS and ultrasonography shows the masses which are not falling into that specific for cancer pathology. Okay, so then in that case, differential diagnosis will be ovarian cyst, uh, ovarian cyst basically, benign ovarian cyst. Then briefly outline management of ovarian cancer, referral to gynecological oncologist, information, stepwise approach, confirm her understanding and ask her, help her to ask questions. Communication with colleague, basically it is cancer MDT. You have to take a name of all cancer people, cancer MDT people. Your cancer support team also will be part and counselor. Information gathering, justifying the investigation. Her RMI is 250, therefore the working diagnosis is ovarian cancer. Confirmation by planning any treatment. So baseline blood investigation, ultrasonography, especially TVS, MRI, CT, abdo to look for the secondaries and even nodes also, and chest X-ray for secondaries. Patient safety points are very less here, but targeted pathway I had mentioned here. Support and counseling will be a very important part of this patient safety points in this case. Applied clinical knowledge, we all are having a very good knowledge about cancer. Grossly, when it comes to cancer module, I will suggest you to have a gross idea about staging. Okay, gross idea about staging and gross idea about that stage, what treatment it requires. Okay, so that if at all there will be a new task regarding cancer from that means from that module, let it be ovarian, let it be CA ovary, or let it be CA cervix, CA vulva. So at least you have a broader classification: stage 1, stage 2, stage 3, stage 4, and what will be the modality in that stage per se will be an important knowledge point what one needs to know in this module. Staging laparotomy, so it will be best result of surgery is if residual disease will be less than 1 centimeter. HPR, adjuvant chemotherapy for 6 months, follow up with clinical examination, CA125 and transvaginal ultrasonography. Use of guideline to inform the clinical discussion and management. Okay, so that's it. Very well done, very well presented.
Thank you, ma'am.
Thank you.